I'm Betsy Kristjansson, co-principal investigator for the Ottawa Neighbourhood Study, and Mike and I, who are the principal investigators, started it back in 2006. So it's been a long-running study, and we're very proud of what we do. And I am also a professor and a principal investigator in CRECS. And now I'll turn it over to Kady to introduce themselves, but I want to say that Kady has been working with us for at least 10 years, and they have grown immensely into this role, from research assistant to basically running the whole show.
Thank you, Betsy, for that intro. So yeah, my name is Kady Carr, and like Betsy said, I've been involved with the ONS for over 11 years now, and I've stuck around because I'm really passionate about the research program and about data in general and about data-driven decision making. My specific interests are in data visualization and storytelling, and the use of data science. And I've been managing the data portion, at least, of the program for quite some time now, and I'm just excited to be part of this great team, both at ONS and part of the broader CRECS team as well. So thank you.
And I would also like to say thank you all for being here. We really appreciate being able to talk about the ONS. It's one of our favorite topics. And we would appreciate any questions from you about it. Okay, so I said that Mike and I have been, now this is a little younger, but I like that picture. Have been investigators since 2006. And we've been working together all that time. And Michael Sawada is a geographer, and he specializes in GIS, and now he's using a lot of artificial intelligence to help understand the neighborhoods. Okay, so basically, this got started when a colleague sent me a report from the Brookings Institute in Philadelphia. And that report said that people who live in lower income neighborhoods pay more for most amenities, and they have fewer amenities. They have fewer stores, fewer parks, everything that you could want in a neighborhood, they have less of living in low income neighborhoods. Physical activity programs, there is, as you know, more access to unhealthy foods and less access to healthy foods. You guys have all heard of food deserts, and that is exactly it. Places in lower income neighborhoods that lack good access to healthy food. And as I said, they have less green space. So that got me really interested and excited that we could possibly do something like that here in Ottawa. Why not? Why not show the policymakers that this happens in Ottawa too? Okay, so first I'll explain what I'm talking about when I say health inequities. We know that there are health inequalities in Canada, and health inequalities mean the differences between people of different groups, like those who are in the upper quintile of the SES and those who are in the lower, those who are Black and those who are white, those who are Indigenous and those who are not. We know that. And a health inequity, some of these inequalities are due to genetics and things that can't be changed. But health inequity is when health differences between groups are avoidable and unfair. And that actually, quite honestly, is most of the inequalities. For example, a genetic difference between men and women, like the rate of breast cancer, that's genetic. But the rate of breast cancer between differential rates might be inequitable between those who are better off and those who are less well off. Okay, so this slide shows it well, this picture. In the first image, it's assumed that everyone will benefit from the same supports, that everyone should get the same level of help. But it still lets the shorter one not seeing. a second image, people are given different supports to make it possible for them to have equal access to the game. And that's what we're talking about when we talk about equity. It's basically providing more resources to the populations who need them more. And the third image, now this is interesting. All three can see the game without any supports or the accommodation because the cause of the inequity, that fence, was addressed. The systematic barrier has been removed. Okay, now this is basically more recent. I think it's from 2016, yes, and from Ottawa Public Health. And here are some health inequities in Ottawa just based on income. So you see that those in the lower income group are twice as likely to report fair or poor general health, 3 times as likely to report fair or poor mental health, and they twice as likely to report 2 or more chronic conditions, and also twice as likely to smoke. Now, I think the reasons that might be considered an avoidable inequality, but it's not necessarily. People who live on low income, I've read a report from England that where women were asked why they smoke. And they reported that they smoked because it gave them a chance to get outside and get a break. Yeah. And so smoking isn't always necessarily all the fault of the smoker. The context can really play an important role. Now, one thing that we were very interested in mapping was the social determinants of health. I don't know if you all have heard of them, but they are the conditions in which we're born, live, age, work, and play. So for example, our neighborhoods, our socioeconomic status, whether we're people of color or not. And it has they all have a very strong impact on health and well-being. Yes, there are genetics that play a role. Yes, there's some behaviors that play a role. But as I've said, those behaviors may be a result of not having the money to buy the things that they need. One other example is I study food insecurity. And a long time ago, back in 2012, we interviewed several women who are living in conditions of low food security. They did not have enough healthy food to eat and feed their families with. We asked them, because too often it's said, that it's cooking or lack of budgeting skills, but it's not. These women know how to budget. They shop the sales, and they also know how to cook and know how to provide their families with excellent food. But they are constrained to buying the higher fat things, the lower food quality things, the rice, the pastas, because it fills the belly. So again, it's a mix of context and personal behavior, but it's not by choice that they buy the unhealthy foods. Okay, so our objectives were and are to better define neighborhoods in order to collect, analyze, and map data on the social determinants of health. And before we started, there were several people calling. Most everybody used census tracts for neighborhood or census dissemination areas. And we thought that it is better to define neighborhoods on the basis of 3 things: on the basis of physical barriers. And we used real estate maps because they know intimately about the neighborhoods. And we also later on started using citizen science to help us define neighborhoods. And we started all this off with funding from Canadian Institutes of Health Research, and they have funded us off and on throughout the project. And I said number 3, we have defined neighborhoods because based on physical barriers. So for example, you wouldn't walk across the Queensway to borrow a cup of sugar from a neighbor. You wouldn't necessarily even walk across King Edward to borrow a cup of sugar. And also, real estate maps. And then we wanted to talk to the people who live in those neighborhoods to find out what they define as their neighborhoods. This picture is one of the first consultations we did with experts in the neighborhoods. And we were drawing a map and dividing it of the neighborhoods up according to a population, according to population density, age, like socioeconomic status. And we had tentatively drawn a map around Richmond. But it turned out that this map that we had drawn around Richmond missed a very important road. It missed the road of the director of the fair, the Richmond Fair. And so they said he cannot be outside of Richmond. So that's one thing the residents know and we don't know that is important to the people in the neighborhood. And neighborhoods also have to be small enough to identify similar pockets of populations, hotspots. I think our biggest neighborhood is 20,000. But they have to be large enough to report reliable statistics. So if you have too few people in a neighborhood, you can't report those statistics. And we have some problems with some of the stats from rural neighborhoods because they're very spread out, but they have a much lower population. Our minimum population is about 2,000. And yeah, as I said, it's defined using data and community input, barriers to movement, census, real estate maps, experts' knowledge of Ottawa communities. And when we first started, we worked with Bob Cushman, the medical officer of health, and he knew inside out all the neighborhoods in Ottawa. But then we also started to realize that we needed to talk to residents themselves. Yes, and Kady says, and these boundaries are periodically reviewed to make sure we keep up with population growth. So now we're entering the third iteration of our neighborhoods based on larger populations. For example, Riverside South, I think it's been split, right? Hasn't it? So we have to divide large neighborhoods. Okay, now the kind of data we collect. Oh, good question, Matthew. How are census areas determined? The quick answer is I don't know. But they're determined by StatsCan on the basis of probably population and things like that. And what was the second question? I missed it.
How are real estate maps used?
Okay, now that is interesting. Real estate maps were used in the initial phase of defining the neighborhoods because real estate maps bring neighborhoods that are alike together. And they are within census tracts usually, but they bring neighborhoods that are alike together. And the real estate agents really know the city. Okay, so we collect data on not only the social determinants of health, such as housing, transportation, walkability, but also and the food, access to services, but also on health itself, the health outcomes itself. We have a great partnership with, we have many great partnerships with people in the community, but one of the great partnerships we have is with a group that uses CIHI data, Canadian Institute of Health Information data, and they share it with us. Anything else? Oh, we also have a great partnership with the Ottawa Police Services. And we are starting a relationship with the Ottawa Paramedic Services, and all along we have had great relationships with the community associations, community health and resource centers, which do so much for their communities. Okay, now I'll turn it over to Kady.
Thanks, Betsy. So just to touch on that question about the boundaries really quickly. So there was a question about how census geographies are determined. They're mostly arbitrary. They're based on population size. So StatsCan tries to break them up into equal-ish population sizes. although they do make sure that they follow major physical barriers like highways and rivers and stuff like that as well. But they don't reflect the social constructs of neighborhoods or the health-based patterns that we see across neighborhoods. And that's really what differentiates ONS, is that we take into consideration the community's view on where the neighborhoods start and end. Matt is saying, I imagine political parties would have good maps too. Interesting. So I'm not sure exactly what you mean by that. Could you?
I think, well, for example, if you're campaigning, I was on a campaign for the NDP a few years ago, and we were in a certain area. We were in the Bridlewood neighborhood, and that was drawn by the political parties. They know what neighborhoods they're more likely to be successful with and what neighborhoods it's not. There's not much use in campaigning. And they know neighborhoods that are the swing neighborhoods that are very important. So good thought, Matthew.
Yeah, that's really interesting too. And so the MLS was, or the real estate maps really used like initially to kind of understand what existed in terms of definitions for neighborhoods. And they've really evolved since then based on community input, and they continue to evolve. And I think it's important to note too that there isn't always agreement on where a neighborhood boundary should be. And we often find that they're, across, two neighborhoods, the residents in both of the neighborhoods might not agree on where the division between them is exactly. And so it's a constant sort of evolving process where we try to get it better every time. But we do make sure that we try to not review the boundaries too often, because we want there to be reliable statistics to compare over time so you can see changes over time. However, like Betsy was mentioning, in neighborhoods like Stittsville, for example, the population just skyrocketed, and we no longer were able to identify sort of pockets of populations and their specific needs. When the population size is too large, that you get a dilution of the data. And so in some cases, it just makes more sense to split neighborhoods into different regions. Sometimes there's, major developments in certain regions that need to be accommodated. So those are the reasons that we do verify, or we do review neighborhood boundaries. Right now, as Betsy mentioned, we're going to be releasing our third generation of neighborhoods, and we're hoping that these will stick around for the next 10 years. And these will be released in conjunction with the 2021 census data, which is coming out soon. We have now received the data by our custom geographies, and so that will come soon. And so Betsy did a good job sort of explaining the type of data that we collect. And really, this is about mapping those determinants of health, right? And it's about painting a holistic picture of what's going on in neighborhoods. And so we get this data from a variety of different sources through partnerships with different community agencies, like Betsy mentioned, like with Ottawa Police Service, with Ottawa Public Health. The city of Ottawa has really great open data sets that we're able to access. A lot of it is collected through primary data collection. We've had students walking streets of neighborhoods and taking, notes on the walkability and on the whether there was graffiti on buildings. And really, we've taken several different approaches to the collection of data. And the whole purpose is to bring it all together into one place at the neighborhood level, so that you can observe relationships between different, types of determinants of health, as well as health outcomes and other types of neighborhood level outcomes, and really get a sense of everything that's going on in the neighborhood. And another piece that sort of differentiates ONS from some other data programs is that so it's not just that sort of demographic piece that we're focusing on, but a lot of what we analyze in terms of data has to do with physical access to services and resources. So from your neighborhood, how far do residents have to travel to get to the nearest grocery stores using network paths, for example? Or, in terms of OC Transpo or public transit, we don't just map the location of the stops, but we look at how many different buses run through, within a 5-minute walk from your house, how many buses walk through that, how many different routes pass by your house or your neighborhood. So we really try to assess everything that's going on in the neighborhood in terms of what residents have access to that can help them, with accessing healthy and affordable food, health services, and green space, so on and so forth.
And Kady,
Yes.
we are also using AI, artificial intelligence, mainly and citizen science for that. Might put about 1,000 pictures up of different green spaces, and the people just joined in and said which green space they liked, and from that he was able to identify valuable green spaces. And also we had seniors with a focus group first, defining what was important to them about green space, what was important to them about white space, which is snowscapes. And then they actually trained an AI on the things that they valued, and which, like if it was beauty, which picture was more beautiful to them. They very kindly went through 10,000 pictures each.
Yeah, that's a really good point, Betsy. So we use crowdsourced data from OpenStreetMap, for example, and we also leverage AI. So Betsy's referring to a convolutional neural network that was used to automate the process of comparatively assessing the walkability of different areas and neighborhoods using Google Street View images. So if you can imagine how many different images you can get from Google Street View at every, X and Y coordinate along your neighborhood. So ONS was able to, through this research, train this model to identify features that humans preferred in terms of walkability, feeling safe in the neighborhood, and those types of things, and then was able to automate the process of categorizing all of the images for all neighborhoods. And like Betsy said, some of them were specific to seniors' walkability, and so the possibilities really are endless around that.
And then with the snowscapes, of course, what was most important to seniors was safety.
Yeah.
So they looked at pictures reflecting safety, and they chose between the two of them, which looked like the safer place. And that was a lot of fun working with those people. And they had a lot of insight, of course, because they're out in the neighborhoods all the time.
Curious. Sorry, just a quick question. Have you done anything around noise? And
that is a good question. I have just been asked by a citizen to do something about noise. And I think a long time ago, Mike had an indicator of noise. So yes, that is one thing we need to explore, because I understand it is a terrible impediment to even conversation in some places, to conversation, to enjoyment of your yards. Good point, Matthew.
Yeah, that could really change as these new buildings are built and traffic increases and so forth.
Yes.
Yeah, and it's really about how do we collect that data, and if there are sensors, we have used some remote sensing to analyze or collect data, but we need enough sample points to represent neighborhoods. And there was a point, as Betsy was saying, that Mike developed an app that would use your phone's audio input to record. So we were trying to crowdsource noise pollution through people's phones. It didn't quite, blow up as we had hoped it would, but it's definitely something that we're interested in looking at. Air quality as well. There are some measures of air quality from the CANU database that we can look at. So that's a really good point.
Thank you, Matthew.
So I'll pull us back here to some of the data that we were talking about in terms of what ONS produces and maps and displays. And we'll talk about some of those knowledge transfer tools in a minute. But this is one sort of outcome of ONS that is widely used. It's the SES index is how most refer to it. And it's a composite measure. It's a principal component analysis that brings together 8 variables from the census, demographic variables relating to things like family composition, employment, education, income, and housing conditions. And these 8 variables are brought together to form an index of socioeconomic deprivation at the neighborhood level. And so essentially there are scores for each neighborhood that overall represent the level of socioeconomic deprivation based on a combination of those 8 variables. And then those scores are converted into what we call quintiles, which just means that all neighborhoods, so they're broken up into 5 equal size groups of neighborhoods. So about 21 neighborhoods in each of the quintiles. There's 5 quintiles, where quintile 1 represents the least disadvantaged group of neighborhoods, and quintile 5 represents the most disadvantaged group of neighborhoods. So on this map that you're seeing here, the darker blue shade represents those Q5 neighborhoods, as they've become known as, sort of, and that's often where many of our stakeholders and partners, it's the first place that they look to identify areas of higher need, is, because there's so much data available. There's different ways to look at income, to look at family composition, to look at, unemployment. But to have one measure, one index that can give you a first glance of an overall view of the socioeconomic deprivation of an area is really helpful to many of the stakeholders that use ONS data. So this is often what's used as a first step for understanding, okay, where do we need to be focusing our resources? Now that we see, which neighborhoods are in the most disadvantaged areas, then we can look at what specifically about these neighborhoods is putting them into the Q5. What is it about? Let's look at closer at their family composition, education, income, and so on and so forth. But this has really been, the most, I would say, used data from ONS in Ottawa.
And with the idea of equity, it's also used to identify where people need more resources, where more resources are needed to help people be more healthy.
Exactly. And I thought that was a question, but thank you, Marcel, for that little clap. So some ways that we can then also use the SES index is to compare the different quintiles of neighborhoods. So we can now say, okay, what does access to grocery stores look like for Q1 neighborhoods, the least disadvantaged, all the way up to Q5 neighborhoods, the most disadvantaged. And this is what allows us to sort of assess the inequities across different groups of neighborhoods. So are the most disadvantaged neighborhoods further disadvantaged in terms of health outcome or whatever else it might be? So we'll show you just a couple examples here. If we look at crime data, so what you're seeing here, the x-axis here represents the quintiles of neighborhoods. So Q1 represents the least disadvantaged neighborhoods. And again, Q5 represents the most disadvantaged neighborhoods. This is the violent crime per 1,000 residents that occurred in 2019. And as you can see here, we have the mean number of violent crime incidents per 1,000 residents, plus or minus the 95% confidence interval. And as you can see here, the Q5 neighborhoods, those most disadvantaged groups, they are, well sort of situated above in terms of violent crime, the Q1, 2, and 4 neighborhoods. There's an exception to this, and that is the Q3. And you may notice at the top here, there's one outlier neighborhood. And this is a neighborhood that has a lot of crime in it. And it's not, this isn't showing crime occurring by neighborhood residents. It's showing crime occurring inside the neighborhoods. So you might be able to guess that this is the Byward Market, and it's a neighborhood that attracts a lot of residents from all across the city at night. It's open. It has a lot of nightlife. So there's a lot more crime that happens in this neighborhood for that reason. So it is skewing the Q3 results here for violent crime, just as it is an outlier. We can say the same thing for shootings. So this is the average number of annual shootings per 100,000 residents. And again, we can see that Q5 neighborhoods, so those 21 neighborhoods that are already socioeconomically disadvantaged, are also the neighborhoods that are facing the highest rate per for a resident of shootings in the neighborhood and violent crime in general. So you could relate this to feelings of unsafety in the neighborhood in addition to their existing socioeconomic challenges. Yes, Marcel?
I was trying to put up my hand earlier, but it didn't work, and then it just disappeared. Is there any way of getting the names of the neighborhoods? I mean, we see the map, but
Yes.
the map doesn't tell me anything without any guides to it saying, oh, this is this area, that's that area. Is there a broken down list with names?
Absolutely. So on our website, so I mean, if you have seen the Coreplex maps on our website, hovering over a neighborhood will tell you the name of the neighborhood, and it will show that any of these indicators on that map. And we can also show you some of the other dissemination tools that we have for this data. And, we can definitely get you data in any format that you're looking for in terms of identifying specific neighborhoods. Absolutely. In this here, it's just a static graph, so I can't show you the neighborhood names dynamically, but we do have online tools that will allow you to do that.
Can you let me know where I can look?
Absolutely.
Yes.
And on the last slide of this presentation, we do have a link to the website. And if you're not finding what you're looking for exactly on the website, you can just reach out to us directly and we can help you out with that. So we can already see, that there's maybe a safety disadvantage in those quintile 5 neighborhoods, and that there is sort of a gradient across the quintiles here, with the exception of Q3. This next slide that I'm going to show you is the same graphs here, but we've removed Byward Market as an outlier. And this just really allows you to see the pronounced differences across the different neighborhoods with that one outlier removed. There is another almost outlier here. Well, it is an outlier. It's Centertown. And that's just because it's in a similar situation where what we're doing here is we're taking the number of crime incidents happening in a neighborhood, and then we're using, as the denominator, we're using the population of that neighborhood. And that's just because we don't want to compare just the number of crime incidents happening across different neighborhoods, because they're all neighborhoods of different sizes. But when we use the population size as the denominator, there is some sort of assumption that there's a relationship between crime and the number of people living in the neighborhood. And when the crime is happening a lot from people coming into the neighborhood from outside of the neighborhood, that's when you can get these outliers where it's not really the best measure to be looking at just the number of people living in the neighborhood. However, there isn't really a better way to compare neighborhoods. You can also look at an area-based sort of density of crime. Thank you, Peter, for sharing the ONS website there in the chat. So I just wanted to show you this as well, so you could get a sort of see that gradient a little better across the different quintiles, to really see that at each level of disadvantage, there are inequities in terms of maybe the safety of the neighborhood as well. This here is COVID-19 infection rates. And so again, we've broken down each of the quintiles of neighborhoods. And what you're seeing here is the it's the infection rate that we've seen in neighborhoods. So the number of confirmed COVID-19 cases per 100,000 residents. And it's from March 2020 to December 2021, after which point we sort of stopped recording these cases because people were testing at home on their own and it wasn't getting recorded into the system. So the data stopped sort of being as reliable. So, but during this period of time, there was a really large difference in the way that the pandemic affected the Q5 neighborhoods, those most disadvantaged neighborhoods. So we have residents who are already living in socioeconomic disadvantage, who are now also more likely to, be affected by the pandemic in terms of infection rates. And you can imagine that there could be reasons for this. Maybe it's working, jobs that are more that are essential worker jobs, or jobs where there more interaction with the public is required. That's just one example. Another example could be overcrowding of housing that we tend to see more often in Q5 neighborhoods. And as you know, during the peak of the pandemic, physical distancing was a really big factor in COVID-19 infection rates. So
And that was the case everywhere, in many, many places. People who were racialized or low income were infected at a much higher rate than, and that did prompt a lot of scientists to start looking at that inequity.
And we did see also this, we just wanted to bring a couple examples here to show you sort of the applicability of the SES index. We did also see similar patterns in vaccination rates. But vaccination rates, having lower vaccination rates in Q5 neighborhoods is largely due to barriers to getting vaccinated and not, resistance to vaccination. So that's just one that we try to be careful about the way that we show that data, because there's often many barriers that prevent people from being able to get vaccinated as quickly as the rest of the population. And I'm just saying now a few things in the chat here. Matt saying, or living in large buildings and having to take elevators to come and go. Exactly. That's exactly it. So the type of housing really affects just how at risk you might be, right? Exactly. If you have to be in an elevator just to get down, you have to be touching the same buttons as everybody else in your building, and just you're more likely to be exposed than somebody who's living in a single detached home, for sure. So in terms of KTT, our knowledge translation and transfer here, and I'm going to speed up a little bit just to make sure that we can get through the rest of this and allow a little time for questions if there are any. But so ONS is really a university community partnership. We live within the CRECS umbrella, and we have many partners that are community partners. We have, once the ONS was sort of established and this data was available, because it started off really as a study, but there was a lot of desire from partners from United Way, for example, to continue to maintain and update this information so that it could be used as a source of reliable neighborhood level data continuously. And so we were, lucky to receive core funding from United Way, Ottawa Community Foundation. We've also received funding to sort of mobilize this information by other agencies and the Coalition of Community Health and Resource Centers. We worked with them to create specific profiles of neighborhoods within each of their respective catchment areas. IBM is mentioned there because IBM originally was a big supporter of the ONS and helped to develop the website, the initial website. And they had a lot of, they had some volunteers that really stuck with ONS for a little while to get ONS up and running in terms of, having that knowledge transfer tool, which was the website. And since then, it's really developed. We've found different ways to disseminate information. So core pleth maps is something that you're probably used to seeing on the website, and that's these types of maps where the darker shaded neighborhoods represent higher value in whatever given variable you're looking at. We have the neighborhood profiles, which is another view where you can see several different indicators of health and well-being for a single neighborhood at a time. And you can sort of see how that compares to Ottawa as a whole. We have dynamic dashboards now. So we started leveraging Tableau and Power BI to create more dynamic views of data that can, where the user can interact with the data in a more intricate way and get more out of it. We have infographics, which is also a great tool to sort of get information across that is easily digestible, regardless of data literacy for the community. And of course, there have been some publications as well. So in terms of the impacts and uses, and I am, Betsy, going to talk about the Ottawa public health. Yeah,
because Daryl wanted us to a while ago, but it definitely is a great partnership.
Okay. Yeah. So, sorry, Daryl, I missed your comment completely. Can you talk a little bit about how Ottawa Public Health has leveraged this data? Absolutely. So impacts and uses of ONS. So, it supports data-driven decision-making at the local level. Ottawa Public Health is a really great example of this. So for many years, Ottawa Public Health has used ONS data to make decisions around where, for example, even just flu clinics should go. This was many years ago. And I think that during the pandemic, when the pandemic started in Ottawa, it really increased the use of ONS, of neighborhood level decision making. So when vaccines were first made available to Ottawa residents, there weren't enough for everybody to get vaccinated right at once. And so Ottawa Public Health had to make decisions around where were they going to open up vaccine clinics, who were they going to let have vaccines first. And so they were able to use ONS data to prioritize populations based on the data that they saw at the neighborhood level. So it was the Q5 neighborhoods. If you lived in a Q5 neighborhood, and so we had a list of the postal codes that were associated with those neighborhoods. They had a lookup tool. If you lived in one of those postal codes, then you could go and get the first round of vaccines before others. And this is really how we help to reduce those inequities at the neighborhood level, is by, we knew that there were higher infection rates in those neighborhoods, and that people were facing the most barriers in those neighborhoods. So Ottawa Public Health also had pop-up clinics that they would run specifically in neighborhoods where they knew that people would be facing barriers to accessing vaccination services. And that's one example. There are so many examples of how the community and community partners have leveraged this data and this tool. The neighborhood boundaries themselves have been incorporated into the service delivery model of many of our partners, like Ottawa Police Service, who now use ONS neighborhoods as their patrol zones, and Ottawa Public Health, that, when it came time to sort of disseminate neighborhood level data, they wanted to use ONS neighborhoods to do that. Ottawa Public Library uses ONS neighborhoods as their catchment areas now as well. They've adopted clusters of neighborhoods as their catchment areas, and many other agencies, including many of the community health and resource centers that are now looking at their catchment areas, but in terms of the neighborhoods that are within them. And the more partners that use these neighborhoods, the more we all have sort of a common language to use for these regions, and the more that we can all share data and really get a better understanding of holistically what's happening in the neighborhood. And, ONS encourages cross-sectoral collaborations. And so we've been at the center of many of these partnerships that have grown and expanded and created sort of a network, a data network within the Ottawa community. And it's able to enrich other research initiatives as well. There's some great work happening at the Faculty of Medicine at the University of Ottawa, and as well as in other areas across Ottawa U, Carleton U, and other areas. And having ONS provides sort of this place-based data that is really a comprehensive data set that researchers from everywhere can leverage for their own research initiatives. And so we're hoping that we'll find more opportunities to collaborate within CRECS as well for other research initiatives that are taking place.
Thank you, Kady. She is our knowledge. She contains most of the knowledge from the Ottawa Neighbourhood Study, and she does a great job. And I would like to thank you all for coming, and also for the questions. And we look forward to a few more if we have time, Peter. And also thank you to CRECS, Center for Research and Evaluation on Education on Community Services.